So thank you. And to kick off the session, I will be talking to you today about developing a multidisciplinary brain metastasis clinic that we've set up at MD Anderson Cancer Center. I'll talk to you about the planning, implementation, and philosophy of that clinic, give you some of the results we've had, and hopefully by the end of this discussion, I will be able to convince you that this brain metastasis clinic has been an effective approach to enhance patient care and to further promote translational and clinical research. So just to sort of get started and to set the tone for the day, as you know, brain metastases are a significant problem in terms of magnitude. It's estimated that at least in the United States, there's approximately 200,000 patients each year with new brain metastases diagnosed. And up to 30%, so 1/3 of patients with stage 4 cancer will just develop brain metastasis. So it's a significant problem. And this problem is actually increasing as more and more patients are living longer due to the systemic therapies that they're receiving. As you know, in terms of incidence, lung cancer, which is the most common cancer, has the highest incidence of brain metastasis, followed by breast, melanoma, renal cell, and colon. But in terms of their propensity to metastasize to the brain, it turns out that melanoma is the most likely to metastasize to the brain, with a patient with melanoma having a 50% chance of a developing brain metastasis. So it's a particularly common problem in melanoma patients. In addition to this being a large problem, it's also becoming an increasingly complex problem. There's a number of reasons for this. First, we're actually now, because we're doing screening MRIs, identifying patients with small asymptomatic lesions, and the question of how to treat these has really become to the forefront. In addition, many of the new systemic therapies have really led to better control of the primary disease. And there's this concept that the brain metastasis should sort of be just another bump in the road as the patient moves forward in their treatment therapy. In addition, the treatment options have really increased and really moved just beyond simple whole brain radiation therapy. Indeed, while in the past, whole brain radiation therapy was the primary treatment, and there was sort of a nihilistic view of brain metastasis, now that view is changing, and there's a lot more options for treatment, making this much more complex. So whole brain radiation therapy, as you'll hear, is much less applied up front. It is not routinely used in many cases and mainly reserved for multiple brain metastasis. Surgery since the 1990s, as you'll also hear from Dr. Ferguson, has now become a standard treatment, particularly for patients with single and large metastases. And interestingly, many lesions that were considered unresectable are now becoming resectable, are now resectable, making surgery an important option. And of course, stereotactic radiosurgery and fractionated stereotactic radiotherapy have become very good treatments for brain metastasis, particularly multiple metastasis. And lastly, we now have systemic therapies. We have many targeted therapies that appear to cross the blood-brain barrier, and immunotherapies are seeming to be effective in a variety of different brain metastasis settings. And so, whereas in the past there were limited approaches, now these approaches are much more complex, and even multiple metastases are able to be treated effectively in the modern era. So this complexity really requires that the patients be treated with a multidisciplinary or a cross-disciplinary approach. Of course, we need neurosurgeons to help with making decisions about surgery, and radiation oncologists to help making decisions about using radiosurgery, whole brain, et cetera. But increasingly, neuroradiology is increasingly involved to help us detect these small lesions earlier on in their course, and neuro-oncology to assist with leptomeningeal disease, as well as the complications of some of our treatment. But most impressively has been the involvement of medical oncologists in the treatment of brain metastasis. We need our medical oncologists not only to help us with the primary cancer site, but also now to help us with many of the systemic therapies that are being used for brain metastasis. So with that in mind, back about 5 years ago in 2016, we put together at MD Anderson a steering committee, a brain metastasis steering committee, and asked them to give us some recommendations about how we should attack this increasingly complex disease. And their recommendation was that we should establish a world-class interdisciplinary brain metastasis center that would have two goals. The first would be to enhance patient care, And the second would be to enable novel clinical and translational research with the hope of developing a new standard, as well as developing a robust database. So based on that recommendation, in the last 5 years, we've actually moved to developing that brain tumor center. We spent several years getting funding and getting the institution behind the idea. In 2018, myself, Dr. Jing Li of radiation oncology, and Dr. Hussein Taubi of medical oncology became the directors of this center. And then we worked in a formal way to progress so that we could open this center in the beginning of January of 2019. And I'd just like to point out that probably the most important decision we made was hiring a advanced practice nurse as a dedicated leader of this clinic at the clinical level. And Alyssa Nguyen has been a highly impactful person in getting our clinic up and running. So one of the main goals of our clinic was to really streamline patient care, increase their income, their input into the clinic, and increase their movement through the clinic in terms of multidisciplinary approach. So we always prided ourselves at MD Anderson on being a multidisciplinary center. But before we started the clinic, I would say that the patients came and moved in what I would call a doctor-centric fashion. A patient would come in, see radiation oncology, and then maybe a day or two later would come to the neurosurgery clinic, and then ultimately maybe go and see medical oncology. This would take several days. In the end, everyone was talking independently to the patient, and then getting back with a formalized consensus view of how to treat the patient often took some time. So the main goal of our clinic was actually to change this to a patient-centric approach, in which now the patient comes to a single center, our brain metastasis clinic. They come on a single day, and now the doctors all come to that clinic and see the patient on the same day together, including neurosurgery, medical oncology, neuro-oncology, radiation oncology, so that a coordinated discussion and decision can be made that can be communicated in one time to the patient. And that would also enhance our potential to get patients on clinical trials. So this was the goal of our patient-centered approach in this multidisciplinary clinic. And that increased our patient satisfaction, but it also increased physician satisfaction as the communication between the doctors increased and the education between the doctors about the different subspecialty and how they can treat tumors, brain metastasis improved. So one of the first things we had to do to establish this was to find a dedicated clinical space. We spent some time getting funding and setting this up. As you can see here, multiple meetings. But the critical element was several logistic things. We now have a clinic 3 days a week on Monday, Tuesday, and Thursday. And as you can see, this is a truly multidisciplinary clinic with all these subspecialties coming to the clinic. And then we have an advanced practice nurse who has directed and really been a focal point of our clinic. We wanted to optimize clinical operations, and we did this through rapid intake of the patient. But most important was the development of a multidisciplinary huddle that we do prior to each clinic, where we review the patient's MRI scans with the neuroradiologist. And we sort of developed a preliminary plan with everyone sitting around discussing what the different disciplines can offer to the particular case. And then all the providers see the patient at the same time. We then step out, make a final decision, and then go back in, talk to the patient, and then pass the information on to the primary providers who referred the patient. Our clinic actually went live in January 3rd, 2019. You can see here in this photo showing how the preliminary review, the sort of the huddle we call it, with the radiologist going over the films, and then all the subspecialty physicians here to make a decision about how to treat the patient. We first started just with melanoma. We then expanded up to breast, and now we include all patients with all different types of brain metastasis. We initially only took internal referrals from MD Anderson, but very quickly we started taking outside referrals, and we actually added a second APN in 2020. So this is now our current clinical team. You can see we have a large number of neurosurgeons, a large number of radiation oncologists. We have neuroradiology support, nursing support with our 2 APNs, neuro-oncology support, but most impressively has been the interest of our medical oncologists to specifically focus on brain metastasis. And we have medical oncologists from melanoma, breast, renal, lung, endocrine, and a whole group of investigational therapeutic medical oncologists who are involved in clinical trials. This has been a great success. In the approximately 2 years since we've started this, we've seen over 507 new patients or consults. As you can see, mostly melanoma, breast, lung, but a whole potpourri of different types of metastasis, as well as enrolling patients into clinical trial, which I'll tell you a little bit more about, as well as very high patient satisfaction and physician satisfaction based on some of our surveys. So the second element was to improve our research, and this clinic has now become actually a nidus for advancing our research. We've actually gone to the lab and developed new models. We have a biosuppository and a biospecimen element to our research. And importantly, we have both a database and clinical trial development. So critical was this development of an integrated database to improve information sharing. Every one of these subdisciplines had their own database in their own department. And the idea was, can we bring them all together into a single database that would overlap and be accessible to all? So we brought together a large team of people again. All their names are shown here. And working together, we now have an organized database that brings all the elements into one place, which we can reuse for both clinical follow and, mostly importantly, for research, both prospective and retrospective. The other element was to try to do clinical trials in this clinic. And indeed, because of this research structure, we now are running our first clinical trial, which is this trial using this novel agent, this novel immunotherapeutic agent. And we are about to start a second trial focusing on patients with renal cell. Over the time, however, we've also been entering patients into clinical trials that are run outside of the brain metastasis center, but the patients are seen in our center, and these include 2 prospective trials. One of the most exciting things we've been doing most recently is actually an advanced tissue-based study. We've developed a program which we call CNS Tumor Analysis Stream, or CATALYST for short. And the goal here is that every patient who goes to the operating room, their tumor is resected, and then it's sent down a tissue analysis pathway, this CATALYST, and it undergoes multi-omic platform analysis with RNA analysis and genomic analysis, chromatin analysis, immune profiling, culturing of the different cells, organotypic slices, proteomic analysis. And then we're also collecting blood and stool on all the patients to understand liquid biopsies and the microbiome. So the idea here is now we can learn from every patient. We've applied this to our brain metastasis clinic. And indeed, since we started this just about 15 weeks ago, we've collected over 200 specimens, and 43 of which are actually brain metastasis. So in conclusion, brain metastasis are obviously a complex problem, but the prior nihilism is now being replaced with what I feel is an optimism as new therapies are developed. And at the core of the advancement is clearly a multidisciplinary cooperation. And our brain metastasis clinic, I think, is a model for this multidisciplinary decision-making at the time of delivery of care. It's also been a central hub for clinical and translational research in terms of database development, clinical trials, and tumor analysis. And ultimately, we hope that this unified approach through this metastasis clinic will help eliminate brain metastasis as a source of morbidity and mortality for patients. I point out that this is only one model and one way of doing it, but we feel that this has been very effective and will hopefully be an example for other institutions across the country and across the world. So with that, I just want to thank all of the people who participate in our brain metastasis clinic. They put in many hours to make it a success, and I truly appreciate all of their effort. Thank you very much.